Two, one. We can start now, ma'am. We can start now, ma'am.
Okay. I welcome you all for another session of the much awaited masterclass by Dr. Abha Majumdar, ma'am. So, after a short hiatus, ma'am, we have ma'am back with a very interesting topic, very pertinent to our daily practice, which is AMH as an algorithm for individualized COS. So, over to you, ma'am.
Thank you, Bhavani. I know all of you would say, what is this every time we go in for controlled ovarian stimulation? But we have to understand how best we can do controlled ovarian stimulation for an individual. So individualized controlled ovarian stimulation, when we want to do that, what is the role of AMH in that? This is what I'm going to highlight today. And I hope I can. And again, I bring my very old but famous slide which shows the birth of Louise Brown. And this was a baby which was born out of a single egg, single embryo, and a single baby. So IVF started to develop fast with the aim of maximizing pregnancy rates per cycle. And I'll just take this to the side. Yeah. And what happened as a result, there was rapid progression of protocols and technology. And what we started doing was we started stimulating the ovaries to get a higher number of eggs and therefore embryos. IVF was very nascent. We couldn't have very good embryo conversion. So we needed a lot of eggs to have a proper embryo conversion. And for that, we used very high doses of gonadotropin. We used agonist long protocol, which all led to higher cost, patient discomfort, higher risk of ovarian hyperstimulation, and higher percentage of multiple gestation. In those days, we would see twins, triplets, quadruplets quite often. So this magic wheel had to slow down, where there were multiple births, OHSS, lot of cost, lot of injections, and we had to make COS better. How could we do that? We could only do that when we started thinking that a definition of success of IVF doesn't depend on pregnancy rate, but it is towards achieving live birth rate per started course of treatment. And for this, we had to, first change was at least change controlled ovarian stimulation. Don't treat everybody similarly. Have different doses and different protocols for different group of people. Such protocols which would lead to adequate eggs, less pain, stress, lesser cost, less complications, and we would have adequate number of good embryos for implantation leading to live birth. So we had to carefully individualize controlled ovarian stimulation. And this was further progression of technology, which was aimed at minimizing complication rate, yet maintaining optimal live birth rates. And then I'll just take you again across a very favorite slide of mine. Louise Brown was born in 1978 without any fertility drugs. And tomorrow she's going to be 47-year-old. What was it? 47 or 40? 72. Yeah, 47 years old. However, the start of IVF was with gonadotropins in the 1970s, and then came in the agonist long protocol. It became very convenient. Cycle cancellation rate was minimized because with gonadotropins, whenever LH surge happened, all of a sudden we didn't know what to do. In 1970s and 80s, we did not even have blood test for LH and FSH. So agonist did lead to very convenient cycles. We could avoid doing pickup on Sundays. We could prevent cancellations, but the cost and complications increased. And then came in the antagonist in the 1990s. That became safer, patient-friendly, and the complications went down. But still OHSS would happen. And so people brought in mild stimulation in the 2000, where which was very patient friendly. You gave either oral medicines or very few injections and aspirated very few eggs. but then one had to repeat cycle after cycle, and the success rate per cycle became very low, and only good labs could give success. So then came in the antagonist protocol, but agonist trigger and freeze all. This was with the start of the 2010 decade, that what was added into antagonist protocol was the agonist trigger and freezing. And that led to almost a ovarian hyperstimulation syndrome free clinic. So this was the real development in the stimulation protocols across 1970 to 2011. And then after this, we started modifying IVF to combine efficacy and safety both with individualized controlled ovarian stimulation. So this is the call of the day. Identify your patient and then give stimulation, which is what we do all the way. So progression of technology happened with conventional stimulation protocols, which aimed at more oocytes but higher complications. Then came in the milder stimulation protocols, aims at less than 8 oocytes but meets very good lab conditions. And then the present stimulation protocols, which is individualized controlled ovarian stimulation, which leads to the best live birth rate per started cycle with lower complications in terms of OHSS and multiple pregnancy. So to practice individualized controlled ovarian stimulation strategies, we needed strategies. How do we do? So what I am going to talk about is expected response. When you see, what do you see to be able to give individualized controlled ovarian stimulation? You look at the expected response. There are other things also which you look into before you start stimulation, but we are only going to talk on this. And what are the things we consider? The age, the weight or BMI, and the ovarian reserve test, out of which AMH is becoming an indispensable test these days. And we also look at the previous response to stimulation. Having said that, type of response, as I told, will depend on all these four things. How do we identify response? Well, we'll have three types of patients. One would be hyper responders, whether they have underlying PCOS or not. One will be normal responders, and the last would be poor responders. And in fact, we have started dividing our patients on the basis of ovarian reserve test to say who would be a hyper responder, who would be a poor responder, and the middle group would be of normal responder. A hyper responder would be underlying PCOS with or without longer cycles, age less, FSH less, AMH high, AFC high, and we might have observed a previous hyperresponse. A poor responder would be longer or shortening of cycles now of new onset. Age more than 37, FSH more than 12, AMH less, AFC less, and previous poor response to conventional stimulation. And then in between these two come the normal responder, who have regular cycles as always before. They've not had any change, recent change in the cycle length. Age less than 35, FSH less than 12, AMH in between 10 to 25 picomoles. Well, if you take it in nanograms, we can very easily say nanogram 1.2 would be less than 1.2 would be a low responder. One between 1.2 and 3.5 would be a normal responder. More than 3.5 would be a high responder. This is exactly when you convert picomoles into nanograms. Does AMH level alone predict fertility? If you remember, I had taken a lecture on AMH also. And I had asked you that AMH I've kept constant, 0.4 nanogram, but the basal FSH changes with the estradiol ratio. So basal FSH E2 is done on day 2 or 3. So I've made E2 constant at 80 picograms per ml, but FSH is 10, 13, 18. Who will perform the best? You all know in your mind. Similarly, AMH same, but menstrual cycles 26 to 28 days, 23 to 25 days, 35 to 45 days. Who will perform best? You have already guessed in your mind. And then AMH 0.5, age 31, age 36, age 41. Who will perform the best? You know. So these are the best performers. Lower age, same AMH will have better performance. Menstrual cycles regular, same AMH will have better performance, and basal FSH and E2 ratio and the same AMH will have better performance than high FSH. So we cannot just go on AMH alone. We need help of other predictors also. So which are the problem groups which we have? The poor and the high responder. High responder, I believe you all feel doesn't matter. But yes, it does matter because these high responders, when make too many oocytes, even if you segment, even if you freeze all the embryos, still the patient can have lot of complications. And we cannot give a young 30-year-old girl who's come to complete her family complications, which take her across lot of morbidity and even mortality. So the response is like this, the lowest response and the highest response. So low ovarian reserve or older women will have only a definite number of oocytes, thus need to maximize oocyte recovery. Now, when they have a low reserve, whether there is one antral follicle or 4, 5, 6 antral follicles, we need to push out all these follicles, and therefore dose doesn't matter. But yes, there is a definite dose after which, however much you may increase, it cannot push out more follicles and more oocytes. Then comes the high responder. We aim at good number of oocytes, but they still hyperrespond, leading to the risk of OHSS. So we must know the exact dose for this group of women, where we would get the desired 15 or less, or 15 to 20 oocytes, so as we can have a fresh as well as a frozen transfer. If you get less than 15, you can probably opt for a fresh and frozen transfer if the patient has no symptoms of OHSS. But if you get 15 to 20, don't opt for fresh. This is a high number of oocytes, and the patient, if gets pregnant, will suffer for the next 2 or 3 months with symptoms of ovarian hyperstimulation. And then comes the normal responder, which is much easier to treat because you know that they will respond normally. They don't have too many oocytes, so you can give them a conventional dose and still they will make 10 to 15 oocytes on an average, which is a very, very good number. The best number is 10 to 15, in which you can proceed with fresh transfer and still freeze 2-3 embryos for future transfer. So strategies for best outcome for normal. I'll start with normal responder, then I'll go to high responder, and then I'll come to poor responder. In normal responder, you can use long protocol, which means GnRH agonist down regulation followed by gonadotropin, or you can use antagonist protocol. Every center may have its own method. Some people use flexible always, some believe in fixed. We feel normal responders do best with a fixed antagonist protocol. And here the gonadotropin dose is generally 225. Very rarely we give 300 to normal responders. Depending if they've had a previous stimulation and less oocytes, then we give 300. And what is very important, that they should be having a good cohort formation is important pre-controlled ovarian stimulation. Then we come to strategies to improve outcomes of ovarian stimulation in high responders. Now here, the first protocol is antagonist protocol. Whether it is fixed or flexible, well, I would prefer to give fixed. So antagonist protocol is number one. Agonist trigger is very important. Freeze all embryos if overstimulated. So this should be the dictum for all high responders. We do not use agonist protocol unless, I don't know, if one has some majburi of doing so. So all protocols require low starting dose of FSH. That means 100 to 200 units, not more than that. And still the ovaries may get overstimulated. Now, algorithm for dose of FSH, this is especially when the AMH is high and these are high responders and PCOS. So what you use is age, AMH, and basal FSH. You see, all these three things I had spoken to you earlier, that basal FSH, age, and cycle regularity are three important predictors of how the patient is going to respond. Here we take age and basal FSH. Now, if you see, this is the age column, this is the AMH column. How do you decide the dose? And this is the FSH column. How do you decide the dose over here? So if you look at this patient, age is 30, her AMH is 4, and her FSH is 4. So this algorithm chart takes two lines across the age and this, and takes this to meet this dot. And where does the dose come? To around 150, right? So this becomes the ideal dose for this patient with the AMH of 4, age 30 years, and the FSH levels of 4. You see? So we take another page. Here we take age, AFC, and basal FSH. So we've not used AMH over here. A lot of people have so much variation in AMH, and which is mostly laboratory induced. So here you've seen again, age is again 30. AFC is around 16. And FSH is again 4. So you take a line between these two and you take it forward. Similarly, you take this line from here and go and meet this. And you'll find the dose of this being around 137.5 to 150 units. So this is the right dose for these hyper responders. So don't use higher than this dose unless there has been some type of poor stimulation earlier, poor drug usage, or poor response. Having said that, you still need to know about OHSS free clinic, because you might still overstimulate your patient sometimes, not being so careful about it. And in 3 steps, we sort of make our clinics OHSS free. First is use antagonist protocol, 2, use GnRH agonist trigger, and last, cryopreserve embryos. Now, does this mean that we can have as many oocytes and all is safe? This is all I want you to understand, that you've been very cautious and you've still used 225 or 200, thinking last time we got very few oocytes and very poor embryo conversion. So you've used 225 for this patient, or maybe even 300 units. And you feel, arey, koi baat nahi, 30 oocytes bhi niklenge. We'll freeze all of them and we'll give her good luteal suppression so that she doesn't have OHSS. But what can we have? Possible drawbacks and health risk of a large cohort of follicles to the woman undergoing stimulation. Have you ever asked your patient who's 15, 16 eggs you've retrieved, how do you feel in the lower abdomen? They feel so heavy, so painful. And this pain continues for the next week or so, which is really very tough for them. When they walk, they feel that the whole lower abdomen is dangling. They have pain. They have sometimes bleeding. And the worst is adnexal torsion, which the girl faces within 3-4 days of her egg pickup, and rarely even thromboembolic phenomena, venous thromboembolic phenomena. And we've seen all of these complications, bleeding, because sometimes you have to do multiple pricks to take out 15 eggs from a ovary. And when you do these multiple pricks, this is a very vascular ovary. You go through a smaller, bigger than capillary vessel, and it can bleed intra-abdominal. And maybe multiple times we've had this, that we had to admit our patients, watch her dropping hemoglobin and give her blood to sort of wait for the bleeding to stop spontaneously. Then there is no chance of fresh transfer if you aim at too many oocytes. And fresh transfer is a very good transfer. The woman is looking so much forward to get pregnant in the same cycle. Freeze-all becomes a rule which has its own perils. People are still working on freeze-all and see that what problems do frozen embryos pose, like we need responsibility and storage of surplus embryos and their identity to be very well maintained. Macrosomia is one reported feature of frozen embryo transfer due to epigenetics, with its antecedent health risk of later on metabolic syndrome and all the diseases associated with that. And there is a small, but there is an increase in childhood cancer possibility. And Scandinavia has done most of these studies, where over 2 lakh babies, they found one instance of a childhood cancer, which was possibly associated with frozen embryo. Out of 2 lakhs, if one cancer comes up, we don't consider it big, but it has been found to be associated with frozen embryos over 20 years of cohort studies in Scandinavia. So what is adequate? We all understand that the cumulative live birth rate increases with the number of retrieved oocytes. But target number of oocytes should be individualized by age, ovarian reserve, and clinical circumstances. There are concerns regarding safety and patient's recovery after excessive stimulation. Best estimate is retrieval of 15 to 20 oocyte in freeze-all cycles, representing a good balance between safety and efficacy. And counseling tools for individualization of stimulation goals are being developed to increase efficiency of cycles. And I just showed you 2 algorithms where you can show the patient that this is the dose and that is why I'm giving you this dose. If she responds a little high or low, you can sort of counsel her that this is the dose by individualizing you into this algorithm. So if stimulation becomes high when planning for fresh transfer, there is a very delicate balance between efficacy and safety. Higher number of oocytes lead to increase in cumulative live birth, but also has this increased risk of complications. And there is a plateau or even declines once more than 15 to 20 oocytes are retrieved. So some people said when too many oocytes are retrieved, the live birth rates don't increase anymore. Therefore, 10 to 15 oocytes have become widely accepted target in IVF cycles, targeting fresh as well as frozen transfer. So now we come to the most awaited group of poor prognosis group. I wouldn't say poor prognosis group because that is a much later terminology which came into our armamentarium. This is the poor responder group depending on the ovarian reserve. So having said that, we need higher doses of FSH and we need to add LH or use HMG to FSH from the day we start stimulation. We can use antagonist protocol with flexible regime here. We can also use GnRH agonist long protocol to make a good cohort. And here we can use it as conventional stop or mini dose protocol. Then we have stimulations where we do 2 stimulations back to back in order to get more oocytes, to make more embryos for these women who appear to be poor reserve patients, maybe high age patients. Even if they are young and they have a poor reserve, we may need to stimulate them maybe twice. And Diostim involves stimulation within 1 menstrual cycle twice, which can accumulate double the number of eggs. Bistim and make embryos. Bistim is 2 consecutive stimulations, and we feel that instead of waiting and stimulating after 2-3 cycles or transferring an embryo, it is much better to stimulate once and then stimulate again from day 2 again. And Diostim fresh with luteal start is again another stimulation coin where you start from the luteal phase, stimulate, make eggs, retrieve eggs, and then you do stimulation from day 2 in the follicular phase in the subsequent cycle. And at the end, all the eggs are thawed, fertilized, and the best embryo is transferred into the patient. And then the last is minimal stimulation with repeat cycles. You have to understand that if the patient has very low reserve, a lot of people still resort to minimal stimulation, but you have to do repetitive cycles if you get only 1 or 2 sites. With conventional protocol in poor responders, we sort of explore the full capability of the antral, preantral follicles, which can all be recruited into dominance into the follicular phase. So pre-treatment for a better cohort is a must in these patients because they have a lower reserve, and hence we don't want to lose on to the cohort. Maybe they have a reserve where we were expecting 6, 7, or 8 oocytes, but we get only 1 or 2 because of the poor cohort. Because once you start stimulation by day 5, 2 follicles have reached 16, 17 size and the others are small. And hence you may have to sort of aspirate with only 2 large follicles and the others all small after 8-10 days of stimulation. So what is used is oral contraceptive pill. Minimum of 14 days should be given when you're using it from day 2 if you want to sort of time the cycle a little faster. Otherwise, it is for 21 days. Estradiol valerate 4 milligrams a day from day 22 in a ovulatory cycle. So please make sure that the patient has ovulated before you give estradiol valerate. If she is a PCOS patient, give her Meprate, medroxyprogesterone acetate to cause withdrawal bleeding. But during the period where she's left MEP till the withdrawal bleeding comes, you can give her estradiol valerate as if she has ovulated. I mean, you pretend that she has ovulated because her progesterone rose. And then in those hormone-free period, don't let the cohort form. But then that is only in PCOS patients. So in poor responder patients, confirm that she has ovulated and then only give estradiol valerate, and you can confirm by serum progesterone. If she's got long cycles and she's going to be a poor responder, then you may give her something like medroxyprogesterone acetate and wait for her periods to come, or give her estradiol valerate in the interval period. Then I've already told you progesterone for 5 days from day 21. Antagonist for 5 days before expected menses. This is also a popular method of cohort formation, but didn't gain that much of popularity because controlled studies did not show much difference in the cohort by using antagonist. But now with the oral antagonist available, maybe this might again gain popularity. So when we talk about Poseidon management of poor prognosis patients, and we take patients with poor reserve, both sides, young and old, then we see that you give ICOS treatment where you use long GnRH agonist or antagonist. When you use antagonist, you use estradiol or OCP priming. These are the two recommended by the Poseidon management group. And you start recombinant FSH 300 units and you add LH. You may add androgens also to the younger group, and you may do duostim. The same goes for the older group, that you add LH, androgens, and duostim. So long GnRH agonist protocol has come into use only in patients of poor ovarian reserve, where the cohort was poor and the antagonist protocol did not give us a good number of oocytes depending on the AMH, and hence we started resorting to long agonist protocols only in this group of patients. And the additives are the same in both, but when in the older age, we need more than 12 eggs for one euploid blastocyst, whereas in the younger age, just 4 to 7 oocytes can yield one euploid blastocyst. So you understand, in a young age woman, if you get 4 to 7 oocytes and you get 2 blastocysts, one would definitely be euploid. Or even if you get 1 blastocyst, the chance is that it is euploid. Whereas in an older woman, to get 1 euploid blastocyst, you maybe need 3 to 4 good blastocysts. Having said that, I bring you to Elvigi's chart, best practice in Poseidon group 3 and 4. These are the ones with low ovarian reserve. If you can see, AFC is less than 5, AMH is less than 1.2. I found this very interesting, that adjuvant treatment you may give or you may not want to give. So they've given both options. If you want to give adjuvant, what are the adjuvants? You can use androgens, growth hormone, and CoQ10 in the younger woman. But when you want to give adjuvant in the older woman, only androgens and growth hormone are recommended. If you don't want to give adjuvant treatment, like I don't give, then you can use either long protocol, or with antagonist you use estradiol or OCP for the cohort formation. And you can also go for duostim. Here also it is absolutely the same. And the start dose for Poseidon 3 is 300 units of FSH and or cholefolitropin or FSH alone. But when you come to the older age group, then you add half of it, half of the dose of FSH as LH also. Cholefolitropin is the long-acting gonadotropin FSH. So we can use cholefolitropin alpha plus HMG or recombinant FSH. Here you use HMG or recombinant FSH. So when you are using recombinant FSH, you can combine it with HMG, or you can also give more FSH, because you might have to give in the later half of the cycle when you use a long-acting FSH, because the levels decline. But ideally, just look at this, that in the younger group, you may not add LH. In the older group, it is a must to add LH if they have low reserve. So rest I'm leaving, because you know what trigger to give in which protocol. So multi-cycle approach to controlled ovarian stimulation could improve all the metrics to define success in poor prognosis patients. So from a cycle by cycle to a multi-cycle treatment planning, the next relevant shift in perspective needed in assisted reproductive technology for ICOS. And in conclusion, future of IVF is characterized by two perspectives. One is that you improve or restore oocyte and embryo competence, especially in advanced maternal age. And for that, mitochondrial enrichment, cytoplasmic, take mitochondria from a younger woman, aspirate the cytoplasm, which is mitochondria rich, and inject it into the oocyte of the advanced age woman. And that might probably lead to having better number of embryos. I don't know what we will do in future to improve or restore oocyte and embryo competence, but that is required. Till then, what we need is that we need to maybe collect so many eggs so that we can make enough embryos to be able to give them a live child, deliver a healthy baby, and make treatment more affordable and patient-centered. So the question is that should the regular implementation of multi-cycle counseling strategy be the next relevant shift in perspective needed in ART? All patients who come with low reserve, whether they are young or old, do we start counseling them that multi-cycle is much better? Once you've made your embryos, you've made 2-3 embryos, then there is a much better chance, 2-3 blastocysts, when I say embryos, then there is a much better chance of you to go back pregnant without having to go for stimulations after one failure or the second failure. This is the duostim which we do at our center. This is the dual stimulation we do at our center, where we start FSH alone or FSH with LH till the dominant follicle is formed. We give a agonist or HCG trigger, whichever, and we do a OPU, and then we wait. We waited for 3 days, but now we wait for 5 days till we know what is the result of the previous cycle oocyte pickup. And if we see that the patient has made 2-3 blastocysts, we may not go ahead with the dual stimul. But if she's made no or one blastocyst, we leave her for 5 days nowadays, and then we start with recombinant FSH or with LH, depending on her age. And across this, we give her medroxyprogesterone acetate from the 3rd day of a pickup, because she's already made a lot of progesterone in her circulation. And by giving her MPA, we are sort of making sure that she follows the PCOS protocol, where this progesterone will blunten out her LH surge and will not let the surge come till we've given her trigger. Whatever you want, you can give here, agonist, HCG, or dual trigger. Everything should work for her, and then we do the OPU again. So when we compare it with other newer stimulation protocols, BiStim protocol defeats the main purpose of duostim, which is to shorten the time of oocyte collection and embryo generation, apart from significantly high dropout rates. What happens in BiStim is that normally we say, okay, we'll do 2 stimulations. She does 1 stimulation, makes a good blastocyst on day 5. Now, there is a lot of temptation for the clinician and patient both. Let us put this into you. If she fails to get pregnant, it's so much of a disappointment that she'll never come back on day 2 for a BiStim. She would always wait for her sorrow to solve, and then she'll come back. So having 1 failed transfer also takes the woman away from the IVF center, sometimes for months also. And duostim fresh is like you freeze the oocytes after the first pickup, then you take out the oocytes after the follicular phase egg retrieval, and then all the oocytes are sort of fertilized, and then the best embryo is transferred. So they do not make embryos and freeze all those embryos in the luteal phase stimulation, because that would increase the cost of freezing. But then you are freezing oocytes, so it is still incurring the cost of freezing. So it doesn't make much sense here. So take-home points would be desired number of oocyte recovery is the starting point towards success of an IVF cycle. categorize patients according to expected response to improve outcome of COS. But yes, we have to look at other factors later on, the previous response. And even if she looks like a normal responder and has appeared as a poor responder in the previous cycle, we might have to change the dose, the strategy, everything for the patient. And even the underlying diagnosis, like if she has endometriosis or there is hypo. Analyze cycles where patients respond differently from the expected response. Look at the cycle. Why did she respond differently? What was the fault? What was the FOI? And did she really respond less than what you thought she would? Must combine efficacy with safety in all women, especially in high responders. Cohort formation is important while using antagonist protocol for low and normal responders. So in high responders, doesn't matter, you've stimulated and she didn't form a good cohort, you still got 10, 12 eggs. But in poor responders and low responders, if the cohort is not there, you may unnecessarily put the patient into the Poseidon category. Adjuvant should be the last resort in poor reserve patients before retrieving oocyte. And thank you very much.
Thank you so much, ma'am, for this interesting and comprehensive talk. We have a few questions. Dr. Anupama is asking what is the agonist stop protocol?
The agonist stop protocol, Anupama, is when you've given agonist to her and she's quite a poor responder. So you don't want to give agonist while you're stimulating her. So you stop agonist when you start gonadotropin, but after 5 days, you will have to add antagonist to her so that she doesn't have the LH surge. This is agonist stop protocol. Some people like to practice it. We never practice it. I've done it in one patient. I'm doing it in one patient now who took depot agonist for 4 months. And while taking it, Bhavani, you remember this patient who came?
She got her
Last
periods
was on
while she was.
26th of June, she got her last injection. So I've started her with a stimulation protocol. I'm not giving her anything. The agonist will wear off after 26. Then I'll assess her LH. And if she needs, I will add an antagonist to her. I'm not going to give her any more agonist. She's been long suppressed. So this is agonist stop protocol.
She also wants to know that is antagonist pre-treatment needed when LH is high in PCOS women?
No. I mean, you would only do a LH high on the previous cycle day 2. And if you've done it in the IVF cycle, once we had thought that it is good to suppress, but it is a very false or virtual suppression. The whole cascade of events which happen due to high LH inside the ovary, they will still happen. So just having a visual suppression of LH, like in, say, ovarian failure patients, you give OCP for 3 months and the FSH will come down from 40, 50 to maybe 7, 8. But that doesn't make her a normal responder. She will still be ovarian failure. Same way in LH hypersecretors, whether you suppress LH in the first 2, 3 days or not, the LH effect is still going to be there within the cascade of the ovarian events.
Dr. Jayashree Sridhar wants to know, in a good prognosis patient, she retrieved only 4 M2 out of 10 oocytes, all with dark cytoplasm, despite long protocols. So will she benefit from a multi-cycle stimulation?
First, Jayashree, I think you need to look into a stimulation that a patient who has an AMH of 2.5 nanogram, AFC 8 to 10 male factor, why did you get only 4 M2s? First, you have to look into this. Do you need to add LH? Do you need to give her a dual trigger? And see if you can make more mature oocytes. And she will definitely benefit from a multi-cycle stimulation. You can counsel her for that. And for the next cycle, you say, first we'll see how many mature oocytes and how many blastocysts you make. And on day 5, we will stimulate you second time if we see that we have not made more than 1 blastocyst or made nothing. Then you must counsel her for multi-cycle stimulation.
Dr. Neeraj Jindal wants to know how to ensure cohort formation in normal responders with antagonist
Bhavani, you
protocol.
do it every day.
Yes, we are using mainly estradiol valerate pre-treatment. but not in normal responders. In normal responders, we usually, because we don't have, there's not much high chance of early follicular recruitment. So, in normal responders, we usually don't use any pre-treatment for cohort formation. But yes, in poor responders, we use estradiol valerate pre-treatment. In patients with the regular 28-30 day cycle, from day 21 or 22, we start estradiol valerate 2 milligrams twice daily till onset of menses.
These are two very relevant points which Bhavani has told you, that in normal responders, early recruitment of follicles generally don't happen because they have a very watertight system of progesterone going down and then FSH going up, and by the time menstruation comes. So you don't need to use pre-treatment in absolutely normal responders, good AMH and normal cycles. But in the ones which have a lower reserve, even with regular cycles, you may have to use something for cohort formation. Yeah.
Dr. Meera wants to know, some patients have AFC normal and borderline low AMH. How should we go about these cases?
See, you have to trust what you are seeing. If you trust your AFC, then possibly borderline low AMH means 1.2, 1.3. And if you feel the AFC is normal, you want to really ensure her AMH, get it done from a more reliable laboratory. We've seen AMH varying between laboratories quite a bit at times. So you can trust your AFC count or you can repeat her AMH.
Dr. Divya Jetwani wants to know, is there any effect on oocyte if we use HMG instead of recombinant FSH? Are granular oocytes more I didn't understand the question. Granular M2 retrieved more.
Divya, all the studies across the world have shown HMG is equivalent to using recombinant FSH. But you know what HMG we are using? We are trying to get the cheapest HMG in market. Any company comes out with HMG, which they are marketing at 100, 200 rupees also, at 400 rupees also. So are we really sure that if you're using 75 units, it has 75? Maybe it just has 20 units of HMG. If you really want to use HMG, use Minopure, which comes from Ferring. That is a very expensive HMG. Why should there be so much difference in the rate? So if there is, HMG is very good, but let us hope that our local companies are not taking out substandard HMG. Otherwise, HMG and recombinant FSH, most of the studies, the Cochrane has already proven that they are of equal benefit to patients. No granular oocytes come out by using HMG unless your HMG is queued up.
Dr. Neeraj Jindal wants to know, what is your upper limit of E2 level, the number of follicles for deciding HCG versus agonist?
You tell them what is our upper level.
Usually E2 levels of 2500 and more than 15 oocytes retrieved. More than 15 follicles. More than 15 mature follicles.
What is your opinion on this? Tejashri is there or no?
Yes, ma'am, I'm there. I'm there.
What?
I think if we are looking at a follicular number which is more than 10 on either sides, like total we are looking at 18 to 20 follicles on the scan, or the E2 is more than 3000, we would prefer
I think 3000 is too much.
Yeah.
Agonist trigger, I would give at 2000 also.
Yeah, but if
and
the
you
follicle
look at
number
the AMH also of the patient.
Yeah, AMH
follicles on both sides. You know, if you have more of intermediate follicles, like 14, 15 millimeters, that number is high. These are girls who go into hyperstimulation.
Yeah, so they would prefer agonist in them.
Yeah, so anyone can have a cutoff of 2000, 2500 or 3000. We used to always say 3000 earlier, then we came down to 2500. Now I feel that I don't want any of my patients to suffer OHS.
Yeah, ma'am. If they are younger and smaller number of more intermediate follicles, good AMH, then we would any day prefer agonist trigger.
Yeah, even with the E2 of 2000.
Right.
Or maybe 2500. Next.
She also wants to know if previous stimulation shows any asynchronous growth in normal responders, then what do you do?
You've just heard, we've answered this question many times, so we can skip this.
Dr.
bit.
Divya Jetwani wants to know regarding luteal support in fresh transfer in poor responders, Poseidon 3 and 4, uh, regarding the role of adding
See, you
estradiol
all
or
have
giving
seen very
HCG.
few fresh transfers, I feel, in today's world, so much of frozen transfer is there. But if you do a fresh transfer, I would want you to not add any E2 at all. You can give HCG in the initial 7 days for luteal support, and you use only a 1500 units of HCG on day 1, 4, and 7. After that, don't give any HCG because it will interfere with the pregnancy test. And you give progesterone. You give progesterone across the board, but why would you add E2? You don't need to add E2 here. Anyone feels they need to add E2? Any logic in it?
Ma'am,
Anyone?
maybe if she's talking about a agonist
She's
trigger,
talking about poor responder.
just poor responder, we could add leupride rather.
Maybe leupride agonist would be a good addition to let LH come up, a little bit in the first few days where you're giving either HCG or LH. One of the two things should be given. If you give leupride, it is bringing pituitary LH. If you're giving HCG, it is doing the work of LH only. So this Tejashree has brought in leupride also. So in fresh transfers, we can also give instead of HCG, leupride on after transfer on the day of transfer, if it is a day 5 transfer. If it is an earlier transfer, then on day 6, 7 or 5, 6, 7.
Another question is regarding pre-treatment antagonist. What is your advice regarding that?
I would love to use it, but I want some papers to ascertain me that there's no harm in using it. I have used it once, and now with the oral thing, I really want to use antagonist in the pre-treatment phase for 5 days to prevent recruitment and therefore make my cohort good. And I think we can use the oral one. What is everyone's opinion, Bhavani, Tejashree, and all the delegates? You all are so learned. You can give your opinion also.
We can try it, ma'am.
We can
Always
try.
it. Yeah.
Because it should suppress the LH, FSH, and therefore follicular recruitment in the late luteal phase.
Madam, but antag may suppress the LH also, which is required for recruitment, whereas estrogen will suppress only the FSH,
I
which
think,
more better.
maybe what you're saying, we'll have to think about it, and that is why antagonist did not become very popular, because antagonist will truly suppress the LH, FSH also. But how much of LH is needed for recruitment? I don't know. You'll have to study. You tell us a little more about it. Who answered this question? Priyanka?
Ma'am, Dr. Anupama from Karnataka, ma'am.
Anupama, tell us, how do you feel that LH is required for recruitment?
Because it will increase the androgens, ma'am, LH. So suppressing LH too much may decrease the androgens also, which will increase the sensitivity of follicles for FSH.
Okay, so this is a good explanation. Possibly, we can always try and see and do a case control, do a controlled randomized trial and see in 10 patients also.
Ma'am, here we are just giving it for maybe 3 days before we start the stimulation.
Yeah,
And as
they
per
don't
the
advise
LH
antagonist for more
window,
than.
we just need 1.2, international units of
If you want to
LH.
suppress, if you want to suppress the early recruitment, we'll have to start from day 21 of the previous.
No.
No,
For
just
antagonist early recruitment, I'll tell you one thing, Dr. Divyani. You are Dr.
Anupama, ma'am.
Anupama. Yeah, even the estrogen we start from day
Yeah.
22, 23, even if we can give it for 7 days before a period is due, that is good. So
that
if
is
it's
good
a
enough to
28-day
suppress.
cycle, yes.
Also, the half-life of antagonist is around 24 hours, and then we are going to stop it from the day of stimulation. So,
Yeah, but what she is saying is that it will suppress the LH a little bit, and LH is needed for
Hmm.
androgen sort of
I
accumulation.
got it, ma'am, but it's not a prolonged suppression like agonist.
Yeah.
It is just for 3 days, and the half-life of antagonist is just
5
24
days
hours.
is normally what
So
is said
by the
with the
time,
latest.
by the time we start the stimulation on day 2 or 3, the
Okay.
antagonist effect would be gone by then because it's just the 24-hour
So,
suppression.
Anupama, this is a very valid explanation which Dr. Tejashree is giving, and your point is also very valid. We can look into some studies where they've used antagonist and they found that it did suppress and it led to a poorer response. Just take out few studies and then put it on this forum and we will all read it. Okay,
Yes,
Anupama?
ma'am.
Ma'am,
Yes, ma'am.
hi ma'am, I'm Loveleen from Chandigarh,
Yeah, lovely.
and I haven't used antagonist myself like this, but just a couple of days ago, I heard somebody, one senior person suggesting that if you're using pre-treatment luteal phase oral antagonist, wait for 1 or 2 days, check the LH levels. Once they start rising, they come to around 1 or 1.2, something like that, then start the stimulation. That was
Okay, so Loveleen, it would be very good if we can take out some literature regarding this. This is a very valid thing, and maybe this is the reason why antagonists never became very popular, apart from the injections being expensive. Estradiol valerate became the drug of choice for everyone. So maybe suppression of LH is the
Same
reason.
thing for OC pills also, ma'am. OC
Yeah.
pills also suppress the LH.
Yeah. So, but OC pills have a 5-day pill-free period before the periods come. So the LH bounces back. So what I would say is that take out some articles, Loveleen and Anupma, and if
Yes.
someone feels that LH is really suppressed on day 2 by giving antagonist, just measure the LH on day 2, and then we go ahead with whatever you all come up and write it on the forum. It will help all of us. I
Yes, ma'am.
haven't used antagonist except very rarely in the beginning when this theory had come up maybe 10 years ago. Since then, I've been using estradiol valerate, but the logic of using is very good and the logic of not using is very good. So let us see what is more logical. Okay?
Right. Yeah.
Dr. Anupama is asking for fresh transfer. What is your E2 cutoff?
I would not transfer if the E2 is more than 2,000 or maybe 1,800. And if I've got more than 15 oocytes, whatever the E2 is, I will not do a fresh transfer. 14, 15 oocytes, no fresh transfer for me. E2 more than 2,000, no fresh transfer. What is everyone's opinion? Just say.
Madam, one question here. In FET, we say between 250 to 450 is good E2 level for a transfer.
Yeah.
Whereas in a fresh transfer, we can go up to 1800.
Yeah, that's what I'm saying. Till 2000 also I might go, 1800. Yeah, in fresh transfers, we go up to 1800, 2000 also. But more than that is
Whereas in
real
FET,
risk of OHSS, and that also if she gets pregnant, the late OHSS, which becomes very bothersome. Instead of enjoying a pregnancy, which she was looking forward to, she's hospitalized and she goes through so much of morbidity.
whereas in FET, we usually cancel the cycle if the E2 is high. Why the difference between FET and fresh transfer in the E2 levels, ma'am?
No, in FET, what FET are you talking about? HRT?
HRT, ma'am.
I've never cancelled a cycle. I've never even seen the E2 levels. So
Okay, ma'am.
put a study in this where they say that the cycle should be cancelled. But how will E2 go so high? If she's on HRT, estradiol valerate, the E2 cannot go higher than 400 or 500.
Sometimes even with 10 milligram, it's sometimes around 2000, ma'am.
10 milligrams of estradiol valerate.
Yes, ma'am.
No, then there's something wrong in the assessment. And in any case, we don't use 10 milligram of oral estradiol valerate at all. We don't use more than 6 milligrams in a day orally. If we want to give a higher dose, we use it vaginally, or we add vaginal source or we add a dermal source. So sometimes, when I was looking at the RIF statement and they said estradiol levels in the building phase, that means in the proliferative phase, probably they meant that when we give oral tablets or vaginal estradiol or dermal estradiol, if the E2 has not risen to over 60, 80, that means the drug is not being absorbed, and that is why the endometrium is not forming. So if your endometrium is not forming well and the E2 levels are low, that is the case when we look at E2 levels. But if the endometrium forms in FET cycles, I have not seen estradiol levels. Anyone else who checks estradiol levels, please come out and tell us and enlighten us a little bit that whether it will help or not. Anupama, I would want you to bring this out from evidence. Get me evidence that oral estradiol can lead to levels of 2000.
Okay, ma'am.
Huh?
Yes, ma'am.
Okay, it's very important to see because either the E2 estimation is wrong. I will start doing a E2 level for my patients now. And I'll see how much it comes in HRT cycles, but I don't expect it to be so high.
Dr.
What is
Sophia wants to know.
anybody else's opinion on this or experience on E2 levels post HRT? Loveleen, have you ever done?
Ma'am, I do not do estradiol levels at all,
Just
but
see the
recently
endometrial-
I have been seeing a lot of papers which say you should target something between 200 and 500. But personally, I have
also
not
read
been
these
doing. I
papers.
rely on the ultrasound.
I'll tell you what, 200 and 500 is then when the endometrium doesn't form. Because I also, the ESHRI RIF guidelines, if you read the guidelines, then in the treatment part, they say, look at the estradiol level. So I thought maybe in HRT cycles, they're talking about HRT levels when the endometrium doesn't form well. Endometrium, why is it not forming? Maybe because whatever estrogen we are giving from external source is not reaching the endometrium. That was the only reason I thought that we can look at the estradiol levels. But once the endometrium forms good, none of us look at estrogen levels.
And ma'am, the vaginal estrogen gives a very high estradiol level. And I really don't know whether it matters so much. You know, with
Does
the
it give
vaginal
high
thing, it
as much
goes
as
to
2000? Chalo, let's do a evaluation. I use vaginal estradiol for patients who don't respond to oral estrogens. I use the same tablet Progenova vaginally. This time I'll do a estradiol level and see how much it goes. And then
Right.
Anupama, I'll come back to you in this forum only. We can write a message that yes, I checked and the estradiol level was very high. We'll find
The-
out. We
and the
will answer
success
your
rates,
question
ma'am.
for sure.
And the implantation rates, ma'am.
Yeah, implantation rates also definitely. That is the most important thing. Anything else anyone wants to discuss?
And there's one last question, that when do you prefer to give Leupride as LPS and what dose?
I prefer to give it in all natural cycles and now also in FET cycles. Like, I'm not giving it to everyone. I'm giving it only when 1 or 2 embryo transfers fail with very good embryos. Then I give Leupride. Is that right, Bhavani?
Yes, ma'am. Earlier you were giving it mainly for fresh transfer and natural cycle FET. Then you now you
read
started in
about-
HRT FET
Yeah, because
also.
I read about it that a little LH from the pituitary will do good. So if we give 2-3 days of agonist, it will secrete some LH from the pituitary, which will help implantation. I read this,
will be
that's
for
why I
the
started giving, but I would want you all to get literature on this. It is only given otherwise in natural cycle FET or in fresh cycle transfer, and that also antagonist cycles, not agonist.
We are done with the questions, ma'am.
Okay. Thank you
Thank
very
you so
much
much,
for joining.
ma'am.
And I thank all of you for, sort of bringing up questions which scratch the brain. Anupma, thank you for bringing out your questions. And please look into answers, everyone. And Loveleen, you also look into this, what you said, vaginal estrogen will lead to very high levels. And that would be great to have answers to these questions.
right, ma'am. Definitely. And
So
thank you so much for an excellent.
Thank you, Intas, for supporting us as always. And I'm so grateful to you for giving us this platform, free platform for us to discuss and learn. Good night.
Thank you so much, ma'am. Good night.
Good night.